We are honored to have a distinguished panel of chairs overseeing this session. Please join me in welcoming our chairpersons for this session. Our very first chairperson, Professor Dr. Sardar Fakhar Imam, internal medicine specialist, diabetologist, endocrinologist. He is a premier medical figure, former Vice Chancellor Fatma Jinnah Medical University, and he previously served as principal or professor of medicine at Rahbar Medical and Dental College and head of department at Sir Gangaram Hospital. A big hand of applause for Professor Sardar Fakhar Imam. Our next panelist, Professor Dr. Nadeem Hayat Malik, a titan in Pakistan's cardiology landscape, premier interventional cardiologist, former head of Punjab Institute of Cardiology. He is uniquely certified in 3 countries, holding fellowship from RCP London, Edinburgh, USA, and CPSP Pakistan. A big hand of applause for Professor Nadeem Hayat Malik. Our next chairperson for this session, Professor Bashir Ahmad Sheikh, a dedicated specialist in internal medicine and a committed member of Pakistan Society of Internal Medicine. May I request Professor Bashir Ahmad Sheikh to be there with us on the stage. Our last chairperson for this session, Dr. Salma Zeib, distinguished physician. She currently serves as Associate Professor of Medicine at Lady Reading Hospital, and she is Vice President, KPK Chapter, Pakistan Society of Internal Medicine. We welcome Dr. Salma Zeib over the stage. As we know, South Asian population faces a disproportionately high and early burden of cardiovascular disease, often driven by a complex interplay of genetics and metabolic syndrome. Professor Wijesinghe, our first speaker, will help us navigate these unique risk profiles and the clinical strategies required to address them. Professor Namal Wijesinghe is the current president of Ceylon College of Medicine and professor of medicine at Sir John Cady University. A dual-trained specialist in cardiology and interventional cardiology from New Zealand and Canada, he brings a wealth of global expertise to a topic deeply relevant to our region, coronary artery disease in South Asians. The stage is all yours, Professor Namal Wijesinghe.
Good morning, ladies and gentlemen. First of all, I must thank the Pakistani Society of Internal Medicine, the President, Council, and Professor Jawad Akram to give me this opportunity and inviting me to speak here. Now, ladies and gentlemen, this is South Asia. I want to bring your attention about the population. India is the highest populated country. It's about more than 18% of the world population. And Pakistan has almost 3% of the population. And Bangladesh has 2.2% of the population, and Sri Lanka, my country, has more than 2.25%. So, about 25% of the world population live in these 4 countries. Every 4th person in the world is from these 4 countries. The same thing, in another way, the world can be divided population-wise into 4 parts, 4 equal parts. The world population is about 8 billion, and 2 billion live in that purple area called the South Asia. So I'm not going to talk about the population. I'm going to talk about a very important disease condition and silent epidemic that is important to all our region. South Asia contributes to about 60% of the global cardiovascular disease burden, despite representing 25% of the world population. The risk of atherosclerotic cardiovascular disease is about 2.4%, and the mortality from atherosclerotic cardiovascular disease is more than 1.6%. If you follow the score calculator of the European Cardiac Society, they say you calculate the risk. If the person is a South Asian, you multiply that score by 1.5. That is how high our risk is. Over last 30 years, the mortality from cardiovascular disease conditions have increased by 30%, and the prevalence of cardiovascular disease conditions have increased by 50%. If you compare the South Asian population with rest of the world, the mean age of a myocardial infarction, the first myocardial infarction in the South Asian region is 52 years, whereas the rest of the world, the mean age of the first myocardial infarction is 58 years. to show you the importance, this is a study done in California by Palaniappan and his colleagues. California is a region where all these populations live, and as you can see, the red bars, these are the proportional mortality rates calculated in the ethnic groups as well as the gender and the age. If you take age groups, males, the highest mortality is in the Asian groups. And except the younger age group in females, the other two age groups, the highest mortality is from the South Asian groups. So the main reason for this is increased cardiovascular mortality. This is what has happened to South Asians over the last 30 years. Earlier, the coronary artery disease mortality was in the 5th place, now it is in the 1st place. The mortality rate has doubled during that period. And the stroke risk also has doubled and is in the 3rd place now. And as you can see, the mortality from the communicable diseases, the maternal diseases, the maternal mortality, the neonatal conditions, nutritional diseases have progressively declined, whereas the mortality from the cardiovascular diseases have gone up. So, the conventional risks, as we all know, do not alone can explain the high prevalence of the cardiovascular diseases among the South Asians. It suggests a combination of genetic, biological and environmental factors. Not only that, we have a very high risk of coronary artery disease, and also the onset of the disease and the severity of the disease is also very high. If you compare the mortality rates less than 40 years, South Asians have like 5 to 10 times higher cardiovascular event rates among the people who are less than 40 years compared to their count. Now earlier I told that the mean age is about 6 years less when compared to rest of the world, but when we compare the Asians, South Asians to the Caucasians, the mean age of the first myocardial infarction is about 10 years less. And one of the reasons could be that we have a very high incidence of metabolic syndrome. That includes insulin resistance, diabetes, hypertension, and so on. So during the next few minutes, I am going to briefly discuss some of these reasons why the South Asians have a very high rate of cardiovascular diseases. One is visceral obesity. The South Asians tend to deposit fat in a different way compared to the Caucasians. And we mainly deposit fat in the abdomen. Right? And this visceral fat is metabolically active and can cause inflammation. So even if your weight is in the normal range according to the BMI, you can still have increased amount of fat deposition in the visceral organs. Now this is a study that was carried out to compare the fat deposition between the Asians, South Asians and the Caucasians. So fat deposition can occur in 3 places, as you can see, in the subcutaneous fat, the visceral fat and the liver fat. And the BMIs, the participants with similar BMIs were compared. And when it was compared, as you can see, the South Asians have higher fat deposition in the liver, and that can be accountable to the higher incidence of diabetes in this group. So the fat deposition is one thing. Then the dietary factors, the way we eat food. And if you really follow the South Asian diets, they can vary from region to region, and populations to population, but sometimes we eat more of refined carbohydrates, trans fats, and saturated fats. That also contributes to higher incidence of obesity, diabetes, and coronary artery disease in South Asian population. And there are some genetic factors like the elevated levels of lipoprotein a. Now this, if you follow the world map over there, and if you take this risky level of lipoprotein a as more than 30 milligrams per deciliter, and 33% of the people with high lipoprotein a are in the South Asian region. And not only that, the 50 milligrams, more than 50 milligrams of deciliter is considered to be a very high level of lipoprotein a, and among the South Asians, more than 25% have that levels. So having higher concentrations of lipoprotein a is one of the reasons why we have this. And just to bring your attention to the lipid profile and the various components of and there are some atherogenic components of the lipid profile, and one of the key component in producing small dense LDL particles, which are the more atherogenic components of the lipid profile, is because of having high apolipoprotein B levels. So we should have less ApoB levels as possible, and on the other side, to form, in the formation of HDL, we need apolipoprotein A1 levels. So in order to reduce atherosclerosis, we should have less ApoB levels and high ApoA1 levels. But what happens to the South Asians? South Asians have more atherogenic lipid profile as characterized by high levels of ApoB and elevated triglycerides compared to rest of the populations. So even though sometimes they have normal LDL levels, because they have high ApoB levels and triglyceride levels, and they have higher amount of atherogenicity. Elevated ApoB is considered as a strong predictor of coronary artery disease in South Asians than their LDL levels alone. On the other hand, apolipoprotein A levels, so ApoA1 levels, South Asians typically have a low level. And as I said, this is the primary component of HDL production, and having low HDL levels are another risk factor for the South Asians to have high coronary artery disease levels. So if you look at the genetic factors, having low ApoA1 levels and having high lipoprotein A levels, and also having a higher ApoB to ApoA1 ratio contributes to the increased risk and early onset coronary artery disease among the South Asians. So these genetically driven unfavorable lipid profiles are also contributing to the higher coronary artery disease levels. Then development factors. As you know, there are several theories that when the fetus is exposed to unfavorable conditions in the intrauterine life, later on they can have metabolic problems in the adulthood, especially when there is maternal malnutrition, maternal stress, hypertension, maternal smoking, and also placental insufficiency. There is a process called fetal programming. I'm not going to go into detail, but later on they can have obesity, diabetes, and also cardiovascular disease conditions. This is not unique to South Asians though, but South Asian women get more of these stressful conditions during their maternal period. Another condition that we don't normally pay attention to, now we are moving from the genetic conditions and the biological conditions into the environmental conditions. South Asia is considered a global hotspot in the air pollution. Now, when you compare smoking, the smoking is less compared to the rest of the world in this region. But air pollution is a big issue, right? And in this region of South Asia has 37 of the 40 the most polluted cities in the world. What you see in the picture is about the fine particulate concentration. You know the fine particulate concentration is the micro particles less than 2.5 micrometers. And these particles can penetrate the innate system and get into the bloodstream, get into the lungs, and can cause systemic inflammation, cancers, respiratory diseases, and so on. And that they are a major risk factor of air pollution, of coronary artery disease. It's not only the ambient air pollution, and also a considerable amount of household air pollution, like firewood and all this biomass fuel combustion inside the house is responsible as well. About 60% of the population in the South Asia live in these highly polluted areas. Pollution in South Asia causes an estimated 2 million premature deaths per year, and a considerable number of these 2 million belong to coronary artery disease. Another point where I was also involved in the study when I worked in Canada as an interventional fellow, we compared the luminal area of the coronary arteries by CT coronary angiography in people who have normal coronary arteries, and we compared South Asians and Caucasians. They were age, gender, and body surface area matched samples. And we could demonstrate that the South Asians, although the body surface area is comparable, have a smaller size coronary arteries. So smaller size coronary arteries can be occluded easily. And lastly, this is how the South Asians are represented in clinical trials. And I have all the details I don't want to go through. I can tell you from each country how many people have participated in the randomized controlled trials. So we are hardly participated in these trials. So we are following the guidelines who have been tested on other people. So ladies and gentlemen, lastly, how are we going to do the best from our preventative aspects? Encouraging our patients to follow a healthy lifestyle, being physically active, doing regular exercises, and also maintaining the weight. And it's recommended to have a BMI of less than 23, it's not 25 as in Caucasians. But one thing, although that recommendation is there, we don't follow the other things, like overweight has to be 26, obesity has to be 28, and pathological obesity has to be 23. And dietary modifications, shifting from the traditional ghee-based diets and avoiding highly refined carbohydrates. Early screening of our population at younger age, we have to check blood pressures, lipid profiles, looking for diabetes, and also once the risk factors are found, they should be managed aggressively. So in a nutshell, the desirable biometrics and lipid profiles should be like this. We have to maintain the hemoglobin HbA1c levels in diabetic patients or in normal people less than 5.7%. Weight circumference is very important in these people because the fat is usually deposited around the waist, and the body mass index should be less than 23. Lipoprotein little a, the measurements are different here. When it takes as milligrams per deciliter, it should be less than 30. Total cholesterol level should be less than 160. And as you can see, the LDL cholesterol level, high risk patients should be less than 70. When they are diagnosed, should be less than 55. And we have to pay special attention to HDL cholesterol levels to maintain more than 40 in men and more than 15 in women milligrams per deciliter. Triglyceride levels, I didn't talk about non-HDL cholesterol level. Nowadays, we consider it as more, is better parameter than the LDL because all these different types of bad cholesterol are there. Okay, thank you very much. And this is what I want to show you. Just 30 years ago from this year, Sri Lankan team won the cricket championship in Lahore. We are very grateful as Sri Lankans to the Pakistani people who supported us that year. And the Pakistan team is now in Sri Lanka. I wish both teams in the 2020 cricket tournament. Thank you very much.
Thank you so much, Professor Wijesinghe. The data on regional risk variation is a powerful reminder that our approach must be as specific as our population's needs. The landscape of hypertension is shifting. Beyond the pill box, we are now looking at how wearable technology, AI-driven monitoring, and novel pharmacological pathways can solve the old age problem of patients' non-coherence. This talk explores how we can bridge the gap between the clinic and the patient's daily life.